Good afternoon and welcome to all of our attendees who have joined us here today and those of you who have accessed and are watching via the recorded events. My name is Karen Doran and I am one of the RN team leads for the Behavioral Support System with North Simcoe Muskoka Specialized Geriatric Services. This year we have moved to a virtual platform in order to provide our annual Leadership and Innovation in Responsive Behavior Conference, which has been taking place during 3 one-hour sessions spread over 3 months. Welcome to the Leadership and Innovation Day in Long-Term Care Session 3. Before introducing today's guest speaker, I have a few important details to share. Please be aware that today's session will be recorded and you will be able to access this recording as well as the first sessions on the NSM SGS website. For this reason, all attendees' microphones are muted and videos are turned off. You will notice that there is a question and answer tab on the bottom center of your screen. Please use this to type in any questions for today's presenter, and we will allow for some time at the end of the presentation to go and be answered your questions. We do have someone monitoring the question and answer box, so please feel free to enter your questions here at any time during the webinar. It is now my pleasure to introduce Monica Menicola, who will be speaking today on minimizing the risk of fractures in long-term care. Monica is the Regional Integration Lead for Simcoe County and Muskoka, Ontario Osteoporosis Strategy. Welcome, Monica.
Thanks, Karen.
Yes.
So today we're going to be talking about minimizing the risk of fracture in long-term care. And I'm going to introduce Dr. Catlin McArthur, who is going to go into a lot more detail. I'm just going to give you an overview of what's happening with the Ontario Osteoporosis Strategy and how that relates in our work with long-term care. Let me oh, there we go. So a little bit about the Ontario Osteoporosis Strategy. It's working to reduce morbidity, mortality, and the cost of osteoporotic fractures using a patient-centered multidisciplinary approach that is integrated across all healthcare sectors. There's 3 priorities: fracture prevention, which I'll touch on a little bit today, health professional education and outreach, which is what we're doing today, and patient education and self-management, with the goal of reducing osteoporotic hip fractures. Just a little bit of information about the number of hip fractures that we see in Ontario every year. There's about 13,000 hip fractures, with approximately 700 hip fractures in this Lynn region every year. So it's the Ontario government or the province of Ontario is the only provincial authority in Canada that has an osteoporosis strategy trying to reduce the number of hip fractures. So it's very innovative. They feel very important about because of the quality of life that a hip fracture can change someone's life dramatically. People can die from the complications of a hip fracture as well. And there's a huge cost to the healthcare system, and an average cost of a hip fracture is $64,000. Almost 50% of the hip fracture patients had already told the healthcare system they were coming. They had already had a previous fracture prior to that hip fracture. And unfortunately, the number of patients who did not receive adequate attention after that recent fragility fracture is alarming. So there's a huge care gap. When we started with the strategy in 2005, there was an 80% care gap. And so the strategy has been trying to reduce that care gap. Just to give you another interesting regional perspective around hip fractures, that in the 2017 Provincial Performance Data Report on osteoporosis management, this region had the highest long-term care admission rates following a hip fracture. So the Ontario Osteoporosis Strategy represents the vision and coordinated work of many diverse stakeholders. And you'll see on the bottom of this screen, many of the large provincial stakeholders that work with us and helped kick off the strategy when it started in 2005. There are many other provincial stakeholders as well now that we work with. There's also regional stakeholders. So many of you that are attending today's session have worked with me at a regional level, and and we also have many hospitals across the province, which I'll speak to in a minute, that are working closely with us to help reduce the number of hip fractures in Ontario. So the fracture screening and prevention program. So this is where it's a internationally recognized post-fracture program, and it has been associated with a decrease in the incidence of new fractures and mortality. So we currently have 28 fracture prevention coordinators deployed in 38 fracture clinics across Ontario. These fracture prevention coordinators link the patient, the orthopedic team, and in that fracture clinic environment to services that manage their bone health. So the family physician, fall prevention programs, self-management, etc. And again, some of you will have had a connection with our fracture prevention screening, uh, fracture screening and prevention program throughout the region. So in these sites, provincially, we've seen almost 90,000 fragility fractures that have been identified, educated, and referred for diagnosis and treatment. So that's we're very proud of this program. And as I mentioned, it's an internationally recognized program. The fracture screening and prevention program has been operational in this LHIN since 2007 when we started at RVH, and we expanded to Aurelia Soldiers and to Collingwood General Marine Hospital fracture clinics just after that. We recently started a vertebral fracture screening program through the interventional radiology program at RVH, and that's been very successful as well. So for patients that come to the fracture clinic from long-term care, I just wanted to highlight, I think this is important because again, you may have uh, received notice from the fracture prevention coordinator that that your resident had been to the fracture clinic, and we were either able to screen that patient or not screen that patient, and so what we have set up through and we're really fortunate because this region was the first region to actually start what we call the long-term care transfer summary sheet for our program. It was the DOCs in this region met with me a few years ago and suggested that if we weren't able to screen a patient in the fracture clinic because they were coming from transfer service and couldn't wait for the screening process, that then we could put something on the transfer summary to just let them know that we did screen them or didn't screen them that day. And so this has been adopted across the province, and I'll show you a copy of that transfer summary in a second. So if they come by transfer service, we usually we wouldn't stop them to screen them just because again the cost of transfer is so expensive, and we don't want to hold that patient up. If they come with a care partner, then we offer screening to them. Sometimes, again, depending on that person who's bringing the person from long-term care, they aren't able to stay for that screening, etc. So if they are, we offer screening to them. And when the screening is completed, Rebecca or Lori, our fracture prevention coordinators in the hospital, will send the family physician a letter to let them know that the patient had been screened, and we were starting the process to get them to the specialist or bone density, etc. And over the last year or so, we've seen orthopedic surgeons doing consult and follow-up with long-term care patients through OTN. And in some of the regions in Ontario, we've actually started to piggyback with the surgeon on OTN calls to do that screening. That hasn't happened here yet in this region, but that is our hope at some point that we'll be able to do that. So here's the form that would come. This was the recommendations from the first page was recommendations from the DOCs that I worked with to get something to on the transfer summary sheet, and then the recommendations for fracture prevention in long-term care residents. And Caitlin's going to talk about the recommendations around fracture prevention and long-term care, but all of the transfer summary sheet information that is sent over to long-term care is based on these recommendations. I wanted to mention we work closely with the RNAO best practice program. So Frida, that works in our region, and many of you have met or spoke to Frida, is working on best practice in preventing falls and reducing injury from falls. So I do work closely with Frida so that, again, we minimize the number of times that you've got people coming to the door. So if there's something new that we need to share with long-term care, I try to work closely with Frida to get that information in while she's coming through the door, rather than having two of us come. So we recently, it was exciting, we recently offered a workshop on the fracture risk scale to all the RI MDS coordinators in the region, and we were the first region to kick off in the province. That was in December, so many of your RI coordinators would have attended. We had about 75% of the homes in the Simcoe Muskoka area represented, and so this will now be being repeated 6 more times across the province. So, Dr. McArthur will be speaking about this tool in her presentation. So now I'm going to introduce Catlin and pass it over to her. Catlin McArthur Catlin's work focuses on improving the lives of older adults. She's a registered physiotherapist and an assistant professor at Dalhousie University School of Physiotherapy. She's also an associate inter-RI fellow. And Dr. McArthur is a co-lead instructor of the continuing education course Bone Fit, which is hosted by Osteoporosis Canada, which teaches exercise professionals about safe exercise and physical activity for people with osteoporosis. And Catlin has done so much work that and many papers, and I am just so honored to have her here today, calling in from Halifax. And so I'm going to stop sharing the screen and pass it over to Catlin.
Great. Well, thanks for the introduction, Monica. I'm just going to share my screen here. Just give me 1 second, and we'll jump into it. All right. So before I get started, I just want to acknowledge all of the other people who have been involved in this work, developing the fracture risk scale that we're going to talk about, the fracture prevention recommendations for long-term care, as well as the team of the osteoporosis strategy that really focuses on long-term care out of the Jarrah Center for Aging Research. All right, so let's jump into the content. So fractures are a big problem. And I'm sure you've all had residents who have experienced a fracture, whether it's a hip fracture or other fractures, and they can cause a lot of issues. So about 2 to 6% of residents sustain a hip fracture each year, which may seem small, but the numbers that Monica mentioned earlier are quite large when you think of it from that perspective. The most common type of fracture that happens in long-term care is a hip fracture. It's about half of all fractures, but we do see other fractures that happen in long-term care of the spine, which often go unrecognized, of the wrist, and of the humerus, and other areas of the body as well. What we know is that about 72% or even higher than that of older adults at high risk for fractures are not investigated or treated for osteoporosis. So as Monica previously mentioned, there is quite a large care gap. And there's actually a recent report that came out of the States that older adults in long-term care with dementia there's even a larger care gap for this population. So it's really important that we are able to identify who's at risk for fracture and make sure that they get the treatment that's appropriate for them. So how do fractures happen in long-term care? So quite often it's related to low bone mass. So just having osteoporosis or a disease that makes you have less bone overall. And also the quality of the bone that you do have is usually not as good as well. And then usually there'll be a trauma. So something like a fall can lead to a fracture. And we know a couple characteristics of residents and a couple scenarios that they might get into can increase their risks for falls. So things like having responsive or reactive behaviors can increase the risk for falls and thus for fractures. Being on sedatives for those behaviors, or other medications that people take, such as diuretics, can increase the risk for fractures and falls. People who have advanced dementia are at an increased risk for fall as well. Residents who have impaired gait and balance, which is usually quite a few residents in the home, are at increased risk for falls and fractures. And the environment can also increase the risk for falls and fractures. So things like tripping hazards, or sometimes if there's a transition in the floor that is between a carpet and tile, sometimes that can cause a tripping hazard, or an area that people might fall. And we also know that a lot of residents will fall when they're trying to go to the washroom on their own. So that can be partly the environment, being in a small space and trying to maneuver themselves around. It could be because of impaired gait and balance or impaired cognition, or really a combination of all of those things. The other way that fractures can occur is, again, that low bone mass resulting from osteoporosis. But it can also, instead of having a trauma to produce the fracture, they can sometimes be spontaneous. And that means they just kind of happen. There's not necessarily one event that led to it, like a fall. Often these spontaneous fractures we see in the spine, and often they go unnoticed. So a lot of times people will have fractures in their spine. Usually they're called compression fractures, which means that the bone in the vertebrae of the spine, or those bones that kind of stack up in our spine, has been compressed. It's been squished, kind of like a marshmallow being squished. And often these are not recognized because the person might not be able to verbalize that they have pain in their back. Sometimes they don't even have pain in their back. So in the community, it's about 2/3 of these spine fractures often go unnoticed and don't come to clinical attention. So it's really important that we kind of have it on our mind that someone might be experiencing this. So spontaneous fractures can occur for a variety of reasons. It could be poor positioning over time. So if the person, it often sits or lies down in a slouched or slumped forward position, there's going to be an increased risk for spine fracture. Sometimes it can happen with sneezing or coughing. Transfers or transitions. So if someone is rolling around in bed, or rolling and then coming and sitting up, or just sitting up out of bed, sometimes that can be an area that can cause these spontaneous fractures. So because we don't know that they've happened, it's really important to be aware of things that might clue us in that something is going on. So a lot of times residents, especially if they can't verbalize their pain or what's going on, they might have increased agitation or restlessness. And this might be because of pain resulting from a spine fracture. So it's always good to check it out and see if that's what's happening. Sometimes people will experience pain with spine fractures, so but they don't always. So don't always just ask somebody if they have pain in their back. Sometimes they might not feel it there. Another common symptom is a feeling of bloating or distension in their stomach. And why people feel this is because as their spine compresses, all of your internal organs and all of your ribs and your stomach and everything have to go somewhere. And so they tend to get squished and round forward a little bit. So sometimes people will feel bloated, distended, like their pants are too tight, those types of things. You might also notice somebody is losing height. So if height is something that you measure, you can also track that over time. So again, it's really important to think about these spontaneous fractures as well as those fractures that happen from a fall. And we know that fractures can be devastating for long-term care residents because they have an increased risk of mortality after experience of fracture, and decreased quality of life, pain, disability. They may become more dependent, so require more assistance with things like walking. They may not be able to walk after having a fracture. So it's really important that we try to prevent these fractures from happening. So the first step in preventing fractures, we know we want to prevent them. What are we going to do? It's really determining who's at high risk. So if we know who's at high risk, we can then target prevention strategies so that we can help prevent that fracture from happening. So how we currently assess fracture risk, or I guess in the past assessed fracture risk, there's two main types of fracture risk assessments. One was called the CAROC and one's called the FRAX. And these were developed for community dwelling older adults. And so they really have very specific criteria that might not be applicable to the long-term care setting. Or you might not be able to get this information very easily. You can calculate the FRAX without getting a bone mineral density test to see what the bone actually looks like. But with the CAROC, you do actually need their bone mineral density test to determine their fracture risk. So overall, they're not really tailored for use in long-term care. The other issue with these two tools is they really predict how likely you are to experience a fracture in the next 10 years, rather than a shorter time period. We know that many residents in long-term care, especially more recently, are not likely to live for 10 years. And so if we're calculating a 10-year fracture risk, we're really underestimating the risk of an imminent fracture within the next year or two. So again, these tools are not ideal. So that led to the development of the fracture risk scale, or the FRS. And this is a new tool, fairly new, I'd say, within the last 2 or 3 years. And I'll explain what it is and how you can use it and where you can find it. So the benefits of the fracture risk scale is that using it can help you prevent fractures, which overall will improve quality of life for residents and improve quality of care as well. The fracture risk scale predicts hip fractures, and it does actually predict other fractures like spine, wrist, pelvis, humerus as well. It was originally designed to predict hip fractures, but subsequent studies have shown that it does predict those other fractures as well for long-term care residents. So it was specifically designed for this population with data from this population. The great thing is that it requires no additional documentation or resources. So it's calculated from the MDS 2.0, which is done for every resident in long-term care in Ontario every 3 months, or when there's a significant change in status. So you don't need to send the resident for additional tests. You don't have to do any other sort of documentation. You can just look at the FRS and have a good idea of what how likely they are to fracture in the next year. So it doesn't require bone mineral density testing, as I just mentioned, and it's been validated across Canada. So it was originally developed with a sample of data from Ontario, but more recently it's been validated in other provinces across Canada as well. So these are two of the studies that, the first one on the top left, this is the study where it was developed, and then at the bottom right is the study where it was validated across Canada. So if you're looking for more information than I'm giving you today and you want to delve into how it was developed, you're welcome to check out these publications. So let's talk about what the FRS score is and what it means. So basically the FRS is scored from 1 to 8, where 1 is the lowest risk for fracture and 8 is the highest risk for fracture. And this is fracture within the next year. So unlike those other tools from the community that predict 10-year fracture risk, this predicts 1-year fracture risk, which is really important for this population. So if we looked at a home, approximately 55% of the long-term care population would be at low risk, and approximately 45% would be at high risk. Of course, that depends on the case mix of your home. So if your home tends to have more residents with dementia who tend to wander, then you might have a higher proportion at high risk. But on average, if we looked at kind of the average 100-bed home, if you had 100 residents, 55 would be considered low risk on the FRS, and 45 would be considered high risk on the FRS. So that should give you an idea of how many people we're talking about in your home. And what are the factors that determine the FRS score? So people who are low risk, or residents who are low risk, will be those who walk in the corridor and they have a BMI greater than 30. So they are a little bit on the heavier side. Or they're unable to walk in the corridor, but they haven't fallen in the last 30 days. So they might be in a wheelchair, or they might stay in bed during the day, but they haven't fallen. Those would be people who are low risk. People who are high risk are those who are walking and have a very low body mass index. So I didn't mention BMI stands for body mass index, and that's a measure of your height and weight. So somebody who is under 18 would be very small. And people who are walking in the corridor with a low body mass index, it doesn't matter if they've fallen or not, they will be at high risk for fracture in the next year. That's for a variety of reasons. So often people who have a much smaller frame tend to have lower bone density overall, but also if they are to fall, they have less cushioning. So they're more likely to fracture if they were to hit their head. The other group that will be high risk is those who walk in the corridor, who have a fairly normal body mass index, so it's between 18 to 30, and they have one of the following characteristics. So they've either fallen before, they've had a fracture before, they have cognitive impairment, so their CPS, or their cognitive performance scale, is 3 to 6, so moderate to severe cognitive impairment. They have a tendency to wander, they're over the age of 85, or they are unable to walk in the corridor and they've had a fall in the past 30 days. So this might seem like a lot of things to kind of take in. The great thing about the FRS is it is calculated in the background for you. So you don't necessarily need to think about all these things. It's calculated in the background in point click care or in other EMRs that you might be using. It's calculated in the background there, so you don't have to think, okay, where do these people fall? It'll just show up for you, so it might say they're a 5, but this just gives you some background as to why they're a 5, what factors went into deciding that. So this is another way to look at it. Instead of a list, we can look at it like a decision tree. And this is actually how the scale was developed. I was using decision tree analysis. So it basically looks at all the factors and then maps them out in a decision tree. And how you read this is you start at the top. So we start at that walking corridor, and then you just follow the branch based on the person's characteristics. So again, this might look like a lot of information. Good thing is you don't have to figure this out. The EMR will figure it out for you and give you a number. But again, this is for your information, so you know what factors went into it. So I'll give you an example of how you can kind of read this decision tree. I'll actually give you a couple of examples. So one example is perhaps a woman. She walks independently in the corridor. She has a low body mass index and she's fallen. So if we start at the top of our decision tree, so she walks in the corridor independently, so that means she has a score of 0 on the item G1DA in the MDS 2.0. Her body mass index is less than 18, and she has fallen before. We end up level 8. And if you remember back to my arrow, level 8 is at the far right, so she is high risk. She's actually in the highest risk group. She's most likely to experience a fracture in the next year. And I'm sure you can all picture someone within your home who kind of fits this profile. Let's go through another example here. So this gentleman, he's unable to walk, so he uses the wheelchair as his primary mode of locomotion, and he's fallen in the past 30 days. So again, we start at the top, G1DA, so he would actually be scored as a 4, and he's fallen in the last 30 days. So we go over here, and he's a level 4. So a lot of people are actually surprised to hear that he is high risk. Anything above a 4 is actually considered high risk. So he's the lowest of the high risk group, but he still is high risk, and that's because he's had this fall in the last 30 days. If he had not fallen in the last 30 days, if we went down this branch to the left, then he would be at low risk because he'd be level 1 or 2. So the last example I'll give you walking through this decision tree is another gentleman. He walks in the corridor with assistance. So he's gonna go down the middle here. His body mass index is in the somewhat normal range, so 18 to 30. He's over the age of 85. So we go to the right here. And he is cognitively impaired. So he has a CPS of 3 or higher. So that will bring us to level 7. And if we go back to our arrow, level 7 will take us to high risk. So though all of these 3 people I've shown you look fairly different and go down the branches in different ways, they're all at high risk of fracture in the next year. So that's the fracture risk scale, how you interpret the numbers, what's low risk, what is high risk, and all of the variables or all of the items that go in deciding if they're low or high risk. So the fracture risk scale really assesses for the risk of hip fracture. As I mentioned, it was developed to predict hip fracture. Other studies that have been done afterwards, like the one that looked at how it performs in different provinces, did check, and it does predict other fractures as well. The only issue is that it might underestimate the risk for vertebral fractures. And this is because vertebral fractures are so under-recognized that even though we had vertebral fracture numbers in our sample that we could look at, we still weren't confident that that was actually the number of true vertebral fractures because they are quite often missed. So just keep that in the back of your mind that, you know, for example, the gentleman who is a 4, though he's on the lower end of high risk, because he's in a wheelchair, he might have poor positioning in that wheelchair. He's sitting a lot throughout the day. Perhaps he begins to slouch as the day goes on. He might actually be at a higher risk for vertebral fractures than hip fractures. So again, just kind of keep that in the back of your mind. And the FRS is calculated based on the variables that are available in the MDS 2.0. So there's other risk factors that may exist out there, but they're not included. And that's just a limitation of the data set we have. We developed it using the MDS 2.0. So of course we can only include things that are in the MDS 2.0. The other side of that, the benefit is that you don't have to collect any other information to get this number. So pros and cons of both. So where can you find the FRS score? Now that you know about it, maybe you want to try to find it. So if you're using point-click care as your EMR, it's going to be the easiest. It's going to be found in your outcome summary report. So I will show you what that looks like. So this might be a familiar screen to you. This is just a test patient that was set up. So one way you can look at it or find it is to go to the MDS tab, to print, and then to specifically print the outcome summary report. So you're going to check that, click on print, and then what will come up is this nice outcome summary report. And these are all of the outcomes or all of the scales that can be calculated from the MDS 2.0. So you'll see at the bottom, the FRS, the fracture risk scale, that's where you'll be able to find it. So we can see this test person has an FRS of 4, so they would be high risk based on our scale. Another way you can do it is by going to the dashboard, and then you'll be able to see the MDS scores there as well. So you can see the FRS is located at the bottom. One other way is to run a report, and you can either run it by just an individual resident. So you can either look up a resident number or a resident name, or you can look at a unit and see what the FRS scores overall are for that unit, or you could even look at a floor, an entire floor. So then you just select whichever date you want to look at. So you can look at a single resident over time if you like, or at one time, or you could look at multiple residents at one time point or over time. There's lots of things you could do. So then you just have to click on the magnifying glass and it'll be down at the bottom here, the FRS scale. So you select that, click update and then run report, and you'll be able to see the FRS scores for whatever you've chosen, whether it's single resident over time, a floor or unit over time, or at one time. So lots of different ways you can look at it. Great, so now we know we've done the first step. I talked a lot about the first step, about figuring out who's at high risk. So what can we do now to prevent fractures for these people who are at high risk? So as Monica mentioned, we have fracture prevention guidelines. These were developed in 2015. They're specifically developed for long-term care. So they're recommendations for preventing fracture in long-term care. And they were developed and meant to be directed at the interprofessional team caring for our residents in long-term care. So there are sections about medication, about diet, about exercise, and other components of fracture prevention. And the focus was really on integrating osteoporosis and falls assessment and management to reduce fractures. So there's kind of the osteoporosis piece, so we need to deal with people's bone health, but we know that a lot of fractures do happen because of falls. And so we know also that if we can prevent falls, we can hopefully prevent those falls, those fractures that happen because of falls. And primarily that tends to be more hip fractures. Of course, there are others, but those are the main ones. So what do the recommendations suggest? This is a nice summary for you, just kind of a high level summary. So what we know is for residents who are at high risk, what's recommended is making sure that they are getting enough calcium, preferably by diet. So the goal is 1,200 milligrams per day. And really we're trying to get this through diet. So if they can't achieve this through their diet, then that's where supplements will come into play. Also, we recommend vitamin D of 800 to 2,000 international units, and this would be supplemental. The next step is to consider medications to treat osteoporosis and prevent fractures. Now, within the recommendation document and on the website, which we'll throw up at the end of the presentation, there's a nice decision tree for determining which medications are the best. And of course, this is a consideration that involves the resident and their family members and all members of the team, because there are different options for different types of medication. So if they have difficulty swallowing, there's different types of medications. If they have kidney failure or poor creatinine clearance, then there's other types of medications. So there's lots of different factors to consider. And sometimes people have considered the medications and they've decided that they don't want to take it. But we do emphasize that it's really important to at least have the consideration, go through the thought process and think if it's something that can be added or if perhaps it's something that is not appropriate at this time. From an exercise standpoint, what's really important is promoting exercise to improve balance, strength, and function. So we know that balance training is the most important type of exercise to help prevent falls in the community. And the same is true within long-term care as well as strength and function. So a lot of times falls will happen when residents are trying to transfer between maybe a chair and a bed, or going from sitting to standing, or as I mentioned before, in the washroom, transferring on and off the toilet by themselves. And so it's really important to work on strength that's going to be functional to help with those transitional movements. It's also really important to implement general fall prevention strategies. And the other thing that's important from an exercise standpoint for residents who are at high risk, that the exercise has to be part of this bigger fall prevention strategy. So exercise alone, we know in long-term care does not prevent falls, but exercise as part of a larger fall prevention strategy does. So things like assessing the environment, thinking about what activities caused the fall, who was around, what were they doing, what were they trying to do, those types of things, assessing blood pressure, assessing other medications that they're on, looking at it from a global perspective. And then hip protectors are also effective at preventing hip fractures in long-term care. Now, there is a lot of, the thing with hip protectors is they have to be worn to prevent fractures. So the biggest problem in the research and the evidence that we have is that usually adherence to wearing hip protectors is pretty low. But in places where adherence is high, we do actually see quite a decrease in hip fractures in that population. So the word consider there is, there because we realize there's a lot of factors that go into determining if hip protectors are appropriate. There's lots of different types of hip protectors, lots of different types of fits. So there's ones that are briefs, there's ones that are stick-ons. And so finding the best one is going to be important, and really the one that's going to prevent fractures the most is the one that's going to be worn. So trying to work with the person, with the resident and their family member to determine what is the one that's going to be worn. If one's going to be worn, is going to be the most effective one. And then working as a team, which we're all really great at doing in long-term care, is really important. So working with the residents and families, combining all of these strategies together to make sure we're meeting their care needs. And you'll notice that a lot of them are, consider, recommend. They're not, you must do this, but at least have the conversation and make sure that they're included as part of the care plan, if appropriate. And if not, just make sure you've had that conversation. You document what the reason is for not doing it. From a behavioral perspective, I mentioned that responsive behaviors can increase the risk for falls. What we know from a long-term effect, or strategies that have a long-term effect on behaviors, looking at a systematic review, are person-centered care, communication skills training, and dementia care mapping. So figuring out dementia care mapping is basically following, there's a very stringent way that it's done in the research, but essentially it's following people who have dementia throughout the day, seeing where there's gaps in care and where there's opportunities for improving that care to meet their needs. So, basically working in a person-centered care model, and making sure that the team and the resident and the family member are all working together to try to mitigate or manage the behaviors that might arise. And from a short-term effect perspective, we know from the literature that sensory interventions and music and activities can have a short-term effect, which I don't want to say is worse, or short-term is not worth it. Certainly there's times where short-term effects can be really important in the moment. If somebody's having a hard time, then short-term effects are certainly appropriate. So these can help kind of bridge those times and then be integrated with those longer-term effects from person-centered care, communication skills training, and dementia care mapping. And so why I bring this up is because we know that people who have increased responsive behaviors are at an increased risk for falls and subsequent fractures. So if we can try to work with that resident to help minimize the effects of the behaviors, the negative effects, then ultimately will help prevent fractures as well. So if we bring this all together, what's really important is regular risk assessment. So make sure if you're able to use the FRS on admission quarterly, or if the resident's status changes. And really, we're using the FRS as a risk assessment. So it's not necessarily going to change over time. It might stay the same, and that's okay, because we're really using it to determine someone's risk for fracture. And it's not necessarily an outcome that we're going to measure. The outcome will be that they haven't had a fracture, and that would show success. But their FRS score might not change, and that's okay. And it might actually, go up as the person has impaired mobility or as their cognition changes. It might go down if they are actually progressing through dementia and they are not as mobile anymore. If they no longer walk, for example, and they haven't fallen recently, then they might be low risk. So it might change over time, but it's more of a risk assessment than an outcome assessment. And then also providing patient-centered care, so making sure to involve the resident and the family in the goals of care and treatment options, including recognizing the role of behaviors, because that's something that's often overlooked. So if you want more information specifically about osteoporosis and fracture prevention recommendations, you can check out our website. There's the link here. It will also be in the chat for you. You could also just Google the JERA Center for Aging Research and then click on osteoporosis long-term care. And we have lots of different resources and they are all free. So you can just click on them and download them if you like. So here's some examples of the free tools that are available on the website. So I mentioned different considerations for osteoporosis medication. So this flow chart in the middle is really good. It walks you through all of the different kind of decision points within choosing a medication. And then there's the safe administration therapy tool, which can, again, think about drug interactions and when you would choose one drug over the other. And then we also have a fraction prevention order set, which goes through the different recommendations. So you can kind of check off if you've at least had a conversation about the different points that should be considered. So again, these are free. You can download them on the website. Also on our website, we have a video gallery. The link will also be in the chat for you there. There's 4 different topics that are covered. And actually there's a bunch of different stories about osteoporosis as well. There's one about residents in long-term care with osteoporosis. The one at the bottom here, Deborah, she has osteoporosis and had several fractures. And so she talks about her experience in long-term care. You might have actually seen her on the news throughout COVID. She's been quite outspoken as well, which is really great. And then we have a video series here with 4 topics that focus on personal support workers, physiotherapists, and physiotherapy assistants, group exercise trainers and exercise professionals, and restorative care. And they give specific examples of exercises and strategies to help prevent fractures from those different perspectives. So for example, what a personal support worker could do, what a physiotherapist could do, etc. And so it goes through different examples for that. For residents and family members, we also have some free tools. So we have a talk sheet that was developed in collaboration with the Ontario Association of Residents Councils. And it basically provides suggestions for how residents and family members can advocate for fracture prevention within the home. So what they can, think about themselves, think about their leadership or administration within the home, and then from a medical perspective as well. The one in the middle is fracture risk factors summary sheet. So it kind of takes the factors that are in the fracture risk scale and just provides a bit of education. So it can be a nice poster to kind of put up throughout the home or to share with people if they're wondering why they might be at high risk. And then the last one is just a summary of the recommendations. So what I went through today, but in a little bit shorter detail. And again, it's aimed for residents and family members. So I just like to finish off by saying, prevention matters. It's really important to try to prevent those fractures as best we can. So how we can do this is using the fracture risk scale to determine who's at high risk. Make sure we develop a care plan for addressing fracture risk, and that includes all those different points. Promote teamwork and interprofessional practice, because everybody has a role to play. And really, we're trying to promote resident safety and improve quality of life, because we know that those fractures can have really dire consequences for people. So I'd just like to thank everybody who has been involved in developing the fracture risk scale, developing the recommendations, and in developing the tools as well. And I am happy to take any questions now. If you can't think of any now, or if something pops to your head later, you can always send me an email at my email address. And you can also find me on Twitter if you are there as well. So I'm
Thank you,
happy to
Caitlin.
answer any questions.
Just looking at the question and answer box, there isn't any questions in there at the moment. If any of the participants would like to enter a question into the box, or even the chat box, if you're not sure how to use the Q&A, that would be great. It was a very well-rounded, comprehensive, very informative presentation. So I think a lot of the questions that might have come up, you've already answered through your presentation. But we'll maybe just wait a second.
No problem.
And Karen, it's Monica, and I was going to mention that anyone that would like the laminated version of the fracture prevention long-term care flow chart that Caitlin showed on the screen, I can mail it out to people so that they have a laminated version of it. And any of the other resources, if they'd like to have them in hard copy, I'm quite happy to send them as well.
Okay, great. I did get a question on alarms. Chair alarms, bed alarms, do you still think that they're recommended in practice now? They've been used in the past a lot.
Yes, so from the research standpoint, the most recent research suggests that they're not helpful for preventing falls. They are good at alerting you to the fact that something has happened. So perhaps you would find that person quicker than if they didn't have an alarm, but they don't prevent the fall from happening. So the person is still as likely to actually fall and potentially have a fracture, but you might know about it sooner because an alarm might be going off. So there's that trade-off to kind of think of. And if somebody is consistently trying to get up out of a chair or get up out of bed, it might actually increase their agitation because it's a really annoying sound, as we all know. So it might actually make them want to get up more rather than less. So you just kind of have to weigh that out. How many people do you have available to keep eyes on people? How frequently are you checking around the floor? Is it actually contributing to their agitation, or is it helping?
I do have another question here. It's great to know that the FRS is included within existing documentation and assessments. Do you find that this is commonly known? And what are some of your recommendations to engage teams to utilize the FRS?
Yeah, great question. So I don't think it's as commonly known. It's fairly new. And so that's why Monica and I are working with others at the RNAO and other stakeholders to get the word out and educate the RI coordinators so that they will at least know and then hopefully spread to the team. So, if you're in your home and you know about it now, you can share with other members of the team. You can always ask, hey, what's their FRS? And then start the conversation with whoever it is you're talking to. If they don't know what the FRS is, then you can educate them on it, come back to this presentation or to other resources on our website and help share it that way. But I think we're starting to get the word out, but I don't think it's very commonly known. I think a lot of people know about within the MDS 2.0, they might know about the ADL long form, for example, but they haven't heard of the FRS because it's newer. So we're working on it.
And
Yeah.
it's Monica again. If any of the homes have had a change in their RI coordinator, that they attended the December session or they weren't able to attend and would like to attend the upcoming session, if you want to reach out to myself or Frida Poye at RNAO, we would be very happy to send the link for the next session that's going to be happening on March the 24th. So again, if a home wasn't able to attend in December and would like to, their RI coordinator, the fall prevention lead, etc., we're quite happy to have them. So just reach out to either Frida or myself.
Perfect, thank you. I don't see any other questions at this point. Okay, so on behalf of the North Simcoe Muskoka Specialized Geriatric Services team and all the attendees, I would like to thank you, Caitlin and Monica, for this very insightful and informative presentation today. It's great. We would also like to thank all the attendees for joining us today and for everyone viewing the recorded session.